thank you all for having us here today. I got to speak to this meeting a couple of years ago, and it was a memorable meeting. One of the things you get to learn to do after a little while of talking to folks is you get to figure out if you kind of have the audience with you, if people are nodding off and that kind of thing. And one of the things that I realized that I'd never experienced when I did that talk a couple years ago was that I had the attention of everybody kind of in the back of the room, but the front two rows seemed not to be with me. They were looking at me, but they seemed not to be with me. And then when I got off the stage, someone mentioned to me that my fly was down. So it was a memorable visit, but it changed my checklist for getting up. There's a zip check before I come on. And so hopefully I'll do better this time. One of the things that I think Maureen helps us grasp is how difficult it has become to do our jobs trying to make healthcare systems work. And I come at it as a clinician. I started practice about 12 years ago. And as I was going through my surgical training, my core question was, how do I become good at what I do? And all of those things that Maureen was talking about, none of that was in my textbooks as a physician trying to learn how to diagnose and treat and be really effective. I was worrying about how to tie knots and how to do operations. And then it would turn out that whether my patient lived or died or survived had to do with all these other complex concentric circles of things like their own behaviors and the people around me and how well they were working together. When we have our debates about what's really happening in healthcare, we focus on where our problems are coming from, either the government or from insurers or from medical malpractice, pains. But what you end up experiencing, because it's not working, just switch. Harder to do. Is this, just, how about we just switch this part, because I threaded it. Give us a minute. We doing any better? Nope. Oh, maybe. All right. There we go. Sorry about that. I didn't have you in the back of the room. I didn't understand why. What we're grappling with when we talk about the ways in which, when we have a political debate about what are the directions to go in healthcare, where we concentrate on and battle over are whether government's going to be a help or a hurt, whether insurers getting involved are just putting too much business into healthcare, whether the malpractice attorneys are just are destroying our way of doing work. And what I can tell you from a practitioner's perspective, it feels like none of them are people that I would say feel like they help. And yet, they're all responding to something that we're not responding to as physicians, which is that they are stepping in because there's a feeling like that system with all of those parts that were described, that it isn't working, that the pieces aren't coming together. And at the root of all this, where it starts, is in fact in that stuff that I've been learning about in the textbooks and in my practice, which is the complexity of what we have discovered over the last century. It's really a roadmap of the science that has evolved. A century ago, we didn't know why people had heart disease and heart attacks, and we didn't know why they had cancers or why they might have mental health problems. Well, we've come through that century and we've enumerated actually 13,600 different ways that the human body can fail. 13,600 different diagnoses and conditions and illnesses. And how do I know that? Pick up your ICD-9 coding book and count the number of diagnoses that are in there. We're going to go to ICD-10, so now it's 66,000 different diagnoses. And then you add in genetics, which is showing that each of the diseases we thought were very simple diseases turn out to be dozens, sometimes hundreds of different permutations. We're getting to the point that every condition is personalized, that it is in fact millions of problems. Now, for those problems, we have discovered 4,000 medical and surgical procedures, 6,000 drugs, and still an unenumerated number of hundreds, perhaps thousands, of remedies from a preventive and wellness perspective to keep things from happening. And our job that has been painted for us is that we're to deploy that capability town by town to every person alive. There is no job like that in the world. There is no industry that is expected to deploy its services regardless of people's ability to pay on the basis of their need out of sheer humanity. The exceptions to that are education, police work, firefighting. We are the people who serve the needs. And as Maureen said, then the question is, what are the assets that we bring? And in the face of all of that need, it feels overwhelming. All of those discoveries, especially in medicine, have become both an incredible boon, a miracle, but also a burden. Now when we look out across the country, we are seeing routine statistics like the number of patients who have coronary artery disease who get incomplete or inappropriate care in our communities is around 40%. On average, an American will end up turning to have an operation 7 times in your lifetime. And when you do, the complication rates are high. Death rates are 5 times the rate of road traffic deaths in the country. And we know that half of those complications and deaths are avoidable. You go to mental health, and we've had discoveries that can make anything from depression to the management of addiction incredibly successful, even though it can seem hopeless along the way. But 90% of our behavioral health patients in our communities receive incomplete or inappropriate care. And so then the puzzle becomes, what are we supposed to do? It can feel like a mountain. It is demoralizing. And then we've added this other picture to it, which is that our patients, our public employers are saying, we can't handle the costs. And at the same time, when we look at the people doing our work, we're in a world that has the most effectively trained people. We have the hardest working, most skilled workforce in the country. They work longer hours, are willing to put in the effort, but they too feel demoralized by some of this discussion and where it's going. And when I think about the kinds of work that you're doing in South Carolina and the chance that we've had with our team at the Harvard School of Public Health and our laboratory called Ariadne Labs to work with you over the last 3 years in trying to turn that story around for surgery, it has been the story of trying to make yourselves capable of solving problems and trying to understand what it means about where we're going. I got to thinking about this one night when I took my kids out to eat an unhealthy meal at the Cheesecake Factory. And then I found myself asking a few questions I ended up writing about in the New Yorker. And the questions had to do with walking into this place. I'd come out of the hospital. It was a Friday night, and the place was packed. I mean, I've never been there. There isn't a wait at least 45 minutes long. And when I got to sit down with the kids, I got to understand why. I have a menu like a phone book, over 350 things that they promise to deliver on. And it ranged from, the high-end miso salmon and pasta carbonara to buffalo wings and beer. They kept the price so that the average entree was below $15, and it was good. They've built this out to serve close to 200 restaurants all over the country. They serve 80 million people and a year. And what struck me about it was my assumption was that this was going to be prefabricated, hit the microwave button, fry it up in the back, and pop it out in a box and make it look pretty on a plate, and that's what comes to you. But I cornered a line cook on his way out the door changing shift. And I said, how did you make my meal? How did you do that? And they told me it was from scratch. And I didn't believe it. Because how do you make 80 million meals a year from scratch and make it remotely similar, of a high quality, that you're going to get people lining up at the door to come in? Maureen talked about the idea of we have enormous variation in healthcare, a huge difference between the results you get depending on where you go for your care, or even within a clinic, depending on the day of the week and who's there that day. And here was this place that was managing to take that variation out and drive it to the high end. And I wondered, how in the world did they really do that? Having come from the hospital, we're also trying to deliver to millions of people services at a reasonable price, at a high quality, with a consistency and reliability that would make people want to be there. Would even, they wouldn't have to wait for it, but they would wait for it, and not just because they needed it and they were desperate and there was no other way. Well, we're aiming to fix what we're doing by doing what a place like the Cheesecake Factory has tried to do, and that is by going big. We are combining, we are merging and consolidating, we're bringing larger and larger and larger teams together. Hospitals and clinics are becoming conglomerates. Most physicians had been in independent practice a generation ago, and that is rapidly changing with the pressure to lower costs, adopt information technology that no one clinic can figure out how to adopt or afford, to accept accountability for performance. We've increasingly become folks who've accepted employment. We're starting to work for some of you. And we're in this radical shift. I've described it as being a shift from a world where we were in a landlord-tenant relationship. You guys in the hospital systems provided the real estate and some staffing. And as Maureen said, I was the customer. And I like that. It was a world where it was just like being a landlord and a tenant. You might be picky about who got to rent the apartment or the office building, but once they were in, it was kind of none of your business what I did in my apartment. And it was kind of none of your business how I took care of my patients and what I did. That story is beginning to change, with organizations taking responsibility for the quality and safety of what's happening, the efficiency and the costs that they're telling other people they'll be able to deliver on. The landlord-tenant relationship doesn't work. And our only problem is the pain that you're feeling right now is that we don't know how to do this. We are wanting to tell the governments, the insurers, that we'll handle this, that we don't need your rules. We don't need your second guessing along the way. But that's because we've decided that we can take accountability and promise results, show that we can achieve what we set out to do. It's a trust. They're willing to trust, but they want to verify. And so as we've dived into taking this on, we're finding, throwing a bunch of accountants and administrators at these problems isn't going to help just by itself. Good medicine couldn't be reduced to
a recipe, just a set of rules that others are going to describe. But then I got thinking as I'm sitting there in this cheesecake factory, is that neither can good food get reduced to just the accountants and the recipes. Every dish requires attention to detail, individual adjustment, judgment. So how do they do that? So I went inside to find out how they did it. I asked them, would you let me hang out in your restaurant? And they said, okay, we'll do that. I went through 2 other restaurant chains who said absolutely not. But this one was willing to finally let me in. And the guy I met was a guy named Dave Luz, who was the restaurant manager for 8 restaurants in the area. And he took me inside his busiest restaurant to show me how it works. He was 47 years old. He'd started out waiting tables, risen along the way until now he was managing these 8 restaurants. And his annual revenue was around $80 million a year. $80 million a year in annual revenue. And that's like a medium-sized hospital. And this was essentially his effort to show me how he was running this place that would have that kind of size of revenue and business. And what he first showed me was just how they'd configured the place. It was laid out kind of like a factory with raw material coming in the back doors with produce and food and everything else. And then comes together as a finished product, kind of rolling out the front to the customers who are out there. And so across the back wall were half a dozen prep crew members chopping and rolling and making sauces and all of those kinds of things. And then the next zone was 40-foot-long countertops where cooks were taking supplies from the prep staff, marinated meat and fish. They had parboiled pasta in little individualized baggies that just needed to be boiled for another 3 minutes to get it all ready. Fresh-made sauces, garnishes, and that on those counters, the teams made the foods, and then I zeroed in on the computer monitors that sat over the stations where they prepared it, and they were positioned head high every few feet. They flashed orders on the screens. They had touch screen tabs with very precise recipes. And as I was looking at it, I thought, well, here's the story of how this kind of place really works. It's on those computer screens, and it's in those recipes that they pop up on the screen, and this is how they do what they do. It's a checklist. It had a little timer. It had a time to target completion, and if you didn't get it done in time for the customers out front, it would turn yellow, and then it would turn red, and you didn't want a lot of red on the screens. The red would sort of flash at you. And so then I got to know one of the people on the line, a guy named Maurizio Gaviria. He'd been working there for about 5 years and worked his way from the back where he'd been chopping and doing all of that stuff to being one of their top line cooks. And I asked if I could just watch him and figure out how he does what he does. And so the crush, the restaurant opened, and then the crush started coming in, and the orders started coming in. And the first order that came up was for hibachi steak. I like the hibachi steak. So I got to see how they were doing it. And I was getting to see how wherever I went, it was good wherever I went. And so he tapped open the order. They wanted a medium rare, no special requests. It was just the way I like it. And he tonged this fat hanger steak onto the grill, soaking in teriyaki sauce, started a little nest of sliced onions cooking next to it, and while the meat was grilling, other orders started popping up on the screen and tap, tap, tap. He started going down the list, pulling them up and getting all of them going. So I went over to the screen and I tapped on the hibachi steak recipe, and I was able to pull it up, and it had these detailed instructions about, you have to make sure you season the meat with certain seasonings, make sure to saute the onions, grill the mushrooms, slice the meat in precise ways, place it on the onions, pile the mushrooms next to it, stack the tempura asparagus beside it, shape the mashed potato tower right next to it with a little wasabi butter, and it had a picture of what the net result should be, and then serve. And there's 2 things that struck me about it. Number one, it was very precise about the ingredients and the aims of what they were trying to accomplish. The steak slices were to be 1/4 inch thick. The presentation was just so. But it didn't say a thing about how to get there. It didn't explain how much to really salt, how much you baste, how to sequence the onions and the mushrooms and meat so they get done at the same time, how to swivel from the grill to the countertop and back so you can handle the flow of everything coming and going, how you sprinkle a pinch of salt here, flipping a burger there, sending word to the fry cook to get that asparagus tempura up for them. There was substantial tacit knowledge that doesn't get reduced to instructions. And that felt a lot like the world we're in too. The second way in which it felt a lot like our world was that Maurizio never once looked at the recipe that was up on that screen. And I thought that was puzzling. I said, "Do you use this?" He goes, "No, I got the recipe right here." So how the heck did this work? He was doing his own thing. He put the steak out on the counter, and then I saw how the system really worked. The kitchen manager came around, and he looked at the steak and the little nest of onions and the mashed potato tower, and he put a rating on everything that came through. A 9 or a 10 was a 9 was near perfect. An 8 required 1 or 2 corrections. A 7 needed 3 corrections. A 6 was unacceptable and had to go back. This one was an 8, he said. The tower was too tight. It looked like, one of those sandcastle things that a kid makes with a bucket. It looked way too processed. So fluff it up. So he took a fork out and fluffed it up to give it just that little bit more appearance. Now, the manager was not only checking the quality, he was also checking the pace. He scanned across the line to look for red flags for when the cooks were falling behind. And he had to decide whether the trouble was to give the cooks a nudge or to give them a hand. He watched also for waste. Wasted food, wasted time, wasted effort. It was that line manager told me, Business 101, use the right amount of goods and the right amount of labor and people to deliver what the customers want and no more. More is waste, and waste is lost profit. Now, Luz, the manager of this regional system, had worked out the staff ratio that kept everybody busy, but not so busy that there was no slack. Their biggest problem wasn't figuring out how many people to have when, but instead wasted supplies and wasted food. If they stocked too much, they could end up throwing away hundreds of thousands of dollars of spoiled food a week. If they stocked too little, they'd be telling their customers that their favorite dishes aren't available, and then they'd be gone. They wouldn't be coming back. So he said groceries can kill a place, and they'd figured that out. And so they track it. During the last year, they'd been able to achieve greater than 97.5% efficiency. What that meant, which is unbelievable, is that they threw away less than 2.5% of their groceries. That their chicken, they'd use every bit of it, but less than 2%. They had guest forecasting to figure out how many folks would come in, what needs they would really have, and ask, are our systems prepared for these people coming in? Have we got all that we need in place? Now, to me, this seemed completely alien, like this was like some kind of hostile planet thinking about this, because we don't have patient forecasting like that. We don't have any push-button waste monitoring like they could do. They don't have hour-by-hour oversight. You know how many times someone has come into my operating room to see how I do and give me a little rating and a little feedback on how often this happens? In the last, now, 12 years of being in practice at my hospital, you know how many times a day someone comes in to suggest, how can we improve this service and work together, and what are the needs here? I mean, zero. The exception was that I actually asked a former teacher of mine to come into my operating room and give me some coaching. And it was an amazing thing just to ask someone to come in, provide a little external review, and subject yourself to how you might be able to make the results a little bit better. Well, I think in many ways, my reaction standing there watching the system is, I don't want that, do I? Do I want those kitchen managers and other folks? I asked Dave Luz if he ever thought about the contrast between the way he ran his place and what it was like to go into a clinic when he saw the doctor. We were standing in his kitchen there, and his face shifted before he could answer. And he said, yes, I have thought about it. I've thought about it a lot. His mother is 78. She has early Alzheimer's disease. He's one of her caretakers, and they have help who comes into the home. But getting her adequate care, he said, is a constant, constant battle. Just that weekend before, she'd had a fall and ended up in the emergency room. In the emergency room, she came in, she had a battery of tests, a battery of scans. No one ever explained what was going on, why these tests were being done, what was happening. They just told her she was going to need to stay overnight. Why? Well, a doctor will see you and tell you. There was never a diagnosis. The next, and you know what, he there's a busy place. He felt like, I understand, these are busy people. But there was no coordinated action plan. The ER doctor told her that there would be one set of things that were going to happen overnight and in the morning. And then the interns finally came and said, no, actually that's not what's happening. This group of things are about to be what's happening. And then a specialist came by and told them, no, it's this third set of things that are about to happen. They spent thousands of dollars on tests. No results ever communicated. And the next communication was a nurse coming by and saying that they'd been told they should go home. So that was 10 a.m. They wanted to get her out and get her home in time for lunch, but no one could get her discharged. When they finally found a unit coordinator, they said, we're on a lunch break right now, you're going to have to wait till afterwards. They waited till lunch, and afterwards, finally around 6 p.m., they got her out, got them ready to go out the door. They had a long drive ahead of them, and she was still in her hospital gown, and now it was just Dave and his mother. And so he went out to get a medical assistant and said, can somebody help me here? My mother's still in a gown, and we're told we have to go, and we got all the discharge stuff, but I got to get her into her clothes and that kind of thing. And they said, no, you're supposed to do that. So, well, it's my mother, and she's completely naked, and I haven't, I don't do this with my mom. And they were hostile. What is your problem? So then finally someone comes in, and they're so aggressive with his mom that he's like, you know what? I'm going to do this. You go on out, and I'll take care of it. And he said, in the end, I had no one to help dress. I'm stuffing my mom's boob in her bra. It's unbelievable. His instructions were to check with a doctor afterwards for the results that they had. They thought the last report he got was that maybe it was a urinary tract infection. Couldn't get through to the doctor who's supposed to get those results for days. When they call the doctor, they said they don't have the results, but that he should go see a neurologist. They take her to the neurologist. The neurologist orders the same test that they had done in the hospital, gives them a medicine that they admitted probably isn't going to work. And he just said to me, it's unbelievable that we would not manage this better. That this is the normal thing. And he said, it is as if there is no one in charge. When Maureen talked about being the dot in the center, that's what he was looking for. There is no kitchen manager. There is no regional manager. There is no one the person can turn to knit what happens to someone like an elderly woman like his mom and bring them together. We are starting to create those dots in the center. And making systems work in healthcare is very hard because we haven't come from that space. We know that there's huge variability in the results and in the costs, and that's disturbing. But part of what's beautiful is we're discovering that the very most expensive places in the system are not the best places in the system. That in fact, many of the places that are among the least expensive are getting the best results. And that means there's hope. That means that if we can get the pieces together right, we can take the waste out of the system. We can take the suffering out of the system, and we can help people do it right. We've come through what I've come to call the century of the molecule, after a friend of mine helped me understand this idea. For the last century, we have learned a ton by breaking all of our problems down to their component smallest parts. So we discovered the gene. We discovered the protein that comes from the gene. We discovered the neuron. We discovered drugs, devices, subspecialists to take care of problems. And breaking things down into component parts has been an incredibly powerful, effective way to give people great care and results. If you have something go wrong with your knee, you want not only a knee surgeon, you want a right knee surgeon. And it matters. Getting very good at one narrow set of things or understanding what a gene does has been really powerful. But now we've arrived in a place where what's emerging is it's how those things connect that is even more powerful. And so our science has become not just what are the genes, but how do the genes interact and connect in the field of epigenetics. The neurons matter, but it's how the neurons connect to create behavior and mood and even consciousness that turns out to be the powerful thing. And in a similar way, it's how all of our pieces of care connect that make for the great result. My mother had a knee operation with a great knee surgeon, but what made the difference was that in the course of a 3-day stay, I counted 63 people involved in her care. 8 different physical therapists, the nurses coming and going, the aides, 63 different people who either touched her and executed on the care or were involved in making the decisions in the care. And whether it worked or not depended on whether it felt like a system or just a bunch of random molecules. Now, the places at the top of that curve, the positive deviants, have turned out to be the places that are more like a system. They're more likely to have the pieces come together. And so when we've started some of our work here with all of your hospitals across the state in Safe Surgery, South Carolina, Safe Surgery 2015, it was an effort to build on the work you've already been doing. It is an amazing thing to watch these people walk across the stage. We were talking with Michael Rose here, and see folks who took problems that we said were simply in the nature of the business. Infections are bound to happen, and there's not much you could do about it, whether it's a knee surgery or someone in an ICU. And then you saw people walking across the stage saying, no, we've learned how to do it. And we can go 12 months, 18 months without it happening at all. It's a complete mind shift, and it's a desire to say we're going to come together and look over all of our own shoulders, have the kitchen managers in there, helping make that possible. Well, this project was then an effort to take on an incredibly ambitious, in many ways foolish kind of plan. It was going to take on half of what patients come into hospitals for these days. which is surgery. We deploy 2,500 different kinds of surgical procedures. They involve many, many, many different kinds of specialties, from ophthalmologists to neurosurgeons to general surgeons to gynecologists. And we said, we want to make it so that we can change the experience of care using a fairly straightforward kind of recipe approach with a safe surgery checklist. When you look at South Carolina surgery by the numbers, you translate those 7 operations in people's lives that you undergo. And here, it's 800,000 operations a year. The number of deaths in surgery following surgery are around 5,000 deaths. I looked up how many car accidents, how many traffic deaths there are in the state. It's about 700 to 800 a year. So you're talking about 6 times as many deaths happening after surgery as happen in traffic accidents. And we used to think these were like infections. They just happen. But what we've come to see is that a third to a half, at least, are avoidable. Now, if we could capture just 10% reduction, you're talking about saving almost as many people from death as could be saved if you could eliminate car accidents in the state. The cost savings are massive. The return for the payers on what this kind of effort could do is huge. Now, we decided to dive into this with very little money, with a tiny fraction of support that amounted to 3 people from our team, 2 people really. It's a guy named Bill Berry, many of you have met, former cardiac surgeon, and Lizzie Edmondson, who has practically lived in this state, coming here and working with you. And then a team of people with Lori Gibbons and Rick Foster helping put together folks, a young woman, Ashley Childress, a systems engineer who's come to visit the hospitals and walk into their operating rooms and ask how it's going and see if we could implement this kind of work. Every CEO in the state signed on board that we're going to give this a try. Appointed a team made up of surgeons, anesthesiologists, nurses, and executive leaders, with a small team from each hospital committing to do this work. Those teams came together and said, we're going to make our own checklist. We designed one with the World Health Organization, and they made one that was based on that, but met needs that people felt were identified here, and a few basic checks before a patient goes to sleep under anesthesia, the most life-saving checks. Key communications about teamwork in an operating room, with people introducing themselves by name, talking about the goals of the case, a kind of huddle that the quarterback can call together to make sure everybody knows the plan, where the ball is going, as one of the anesthesiologists put it. Here was added something I think was really fascinating, important, and spoke to your understanding of what teamwork means here, is that it asked the surgeon to say, kind of in their own words, but along the lines of, does anybody have any concerns? And if you see something that concerns you during the case, please speak up. You understand what an ambitious effort this is. On the one hand, this is the kind of project that seems really simple. It's just a bunch of checks. On another, it was asking for a level of communication and success as an intelligent team of people to be able to collectively work together and communicate without fear, be able to raise doubts and questions, even question what and why the surgeon was doing what they were doing. What we see in places that have taken on your projects, whether it's door-to-balloon time, reducing 39-week admissions, or this work, is that a system has certain skills. They have the ability to put together a plan that has to come from engaging people at the top level. They then go, we took them through 3 waves of an education series, a 12-week webinar course, make visits and check on one another, have team training and really bring people together, and then measure what the impact is of the work you're doing. And so the skills you see reflected here are, number one, the ability to recognize failure, which means use data. When everybody just has a piece of care, you don't know what the net result is. Things can be invisible. And you have the power of all payer data in this state. You've moved ahead of many other states by saying that you want to have that data and have it accessible. And so we used that and found that there was a 1.4% inpatient death rate in surgery in the state. That was the failure. And then the question became, could you move it? Skill 2 was devising a solution for the priority problems. And the example came out of work we'd done designing that checklist with the World Health Organization that was a simplified form of what you had produced. And what we saw by taking it to just 8 hospitals in 8 cities, and even within those hospitals just working in certain operating rooms, was that every hospital, if they could get people to make the change, reduce their complications. The average reduction in complications and deaths was more than 1/3. And so there seemed to be an answer about what could be possible and what you could do. But what you also come up against is resistance, inevitable resistance, because we are changing from the landlord-tenant relationship. And so when we were embarking on this project, it was to ask if you could persuade clinicians to try something where someone else was coming in and asking them to change the way they practice. It's like asking a mother to change the way that they feed a child. It takes some persuading along the way. But what we found was that about 80% of folks found that the checklist was easy to use, improved the safety, improved communications. But that there was also about a 20% group on the other side. Took too long, was a pain, I don't need this. And then we asked them, if you were having an operation, would you want the team to use the checklist? 93% said they did. You don't get 93% of agreement on anything. We were starting to see glimmers that you could move this kind of checklist into wider practice. And in the Veterans Administration, they implemented it across about as many hospitals as exist in the state of South Carolina. In the VA, they put in teams that stopped the ORs for a full day except for emergencies and train people on how to use these checklists, and then put people back to kind of coach people along in how to keep the change going. And it took a year. But after a year, they got high enough adoption to have cut the death rates 18% across a large population with good controls indicating this was real. And so the challenge we had was, could we for the first time take a state, a whole population, in a private health system, not one owned by the government, and voluntarily get the profession to change before the regulators and others said this is what's going to happen. Change is possible, but learning how is what matters. In Canada, they passed a law that you have to adopt this kind of work. In Ontario, they just published the results about a month ago, where they measured 3 months before the mandate, and then 3 months after, they went to the hospital and said, are you doing the checklist? And of course, all the hospitals, yes, we are. We're doing the checklist, absolutely. Measure 3 months afterwards, and what do you think the result was? No change in mortality. Lots of paperwork. That is what we did not want to see in South Carolina. We were going to take a different approach and see whether we could make a change. It's been a long road walking through those steps along the way. But in the end, 52 out of the 60 hospitals got through the whole educational series, got their teams together, trained in these webinars, had over 220 clinicians trained in over 6 OR team training sessions. You had clinicians trained in 275 clinicians in in-person meetings, 92 hospital visits where you let us into the operating rooms. Our teams, this joint team from Harvard and the South Carolina Hospital Association, you let us come watch and give advice and say, yeah, this is an 8. There are a few corrections to be made. And that in itself was revolutionary. One of the things that I think we really found was that leadership matters. Leadership matters a great deal. Many of the places that are having the most success with the safe surgery work were the places also had the easiest time with nobody had an easy time, but we're often the most successful with the door-to-balloon efforts, with the pre-39-week elimination of elective child delivery. And it goes back to many of those cheesecake principles. There's a team we've begun working with at the Harvard Business School called the World Management Survey Team. They survey management and leadership across institutions around the world in manufacturing, in retail, and they've begun measuring in education and healthcare. And they measure across what they called Business 101, which was the same stuff that was going on in the Cheesecake Factory. They ask questions like, is the layout of the hospital organization not conducive to workflow, or do they work on optimizing it to serve the patient's needs from a patient-centered perspective? Just in the same way they would look at that retail establishment and say, have they configured the place to work well? They ask questions around performance. Is performance reviewed infrequently and in unmeaningful ways, or is it continually reviewed based on tracked measures and feedback and an aim of continuous improvement and ensuring real communication? Do we remove poor performers as soon as weakness is identified or corrected? These are painful points for us. There's none of us that feel that we can really describe that. And sure enough, that if you look at the management practices on a scale of 1 to 5, we have almost no 4s and 5s in the country. They've surveyed now close to 2,000 hospitals in their management capability. The US is better than the rest of the world, but there's far more variation within the country than there is between countries in what happens. Fascinatingly, you get to see how we compare. The blue is manufacturing, the red is healthcare, and the pink is schools. So okay, we're a little better than schools, but we're not where manufacturing has turned out to be, or retail, like a Cheesecake Factory. But when we started comparing, we started looking across in South Carolina. We looked at the top 5 implementers and walking through this process, and the 5 that have had the greatest struggles in implementing. And this is where you, who are leaders here, turn out to make a huge difference. The places that had the least struggles had engagement of senior leaders and commitment. They had supportive processes. The red are the ones who really didn't. They'd had a history of having tackled, or that's readiness. They were more likely to have tackled projects before and had some success and learned from them. And they really focused on a relational approach, trying to go one-on-one to the people who needed to change and say, here's why we're doing what we're doing. Can you help? I'm going to show you some results now, after more than 2 years of incredibly hard work. And what you see is, number one, that as the hospitals get better at implementing, and here's their implementation score, their improvements that they're reporting in their teamwork, their efficiency, and their systems change correlate directly. The statistical significance is so low you can't even get the number of zeros on here to get to 0.0001. It's a direct correlation with how effective they are. And here is what we are starting to see. The hospitals that first came through the first wave of trainings were in a matched place in 2010. We started with a group of 19 hospitals. It's now spread to all of the hospitals. And in 2013, a year after they've been through that process, they've begun to separate. Now, 1.4% to 1.2% doesn't look like a lot, right? It's a 15% reduction in deaths. There is no drug. There is no device that can do that. This is close to 200 people already clearly saved. That's like a quarter of the car accidents in this state. Now, I'm leery about making this very public yet because we don't know where this curve will continue to go. Will it continue to go downward? Will this curve join the other curve so there can start being 500 and 600 and 700 and 800 lives? We've been looking at the next wave of curves to see whether this is joining, but we know something is happening. And we know it as much from just going into the operating rooms and standing there and feeling what it is like. Chris Wright, cardiac surgeon at Greenville, told me a story. We'd asked him, can you tell us where you felt like it's made any difference? He's like, every day it makes a difference. And every day the thing he feels is that the staff are starting to understand who work with him, the other physicians, that they are a team. And that's a very hard thing to get across, that feeling and experience of it. He said, you know when there's a team, when people are willing to raise questions even if they might be wrong. Because your greatest fear is questioning the surgeon. What are you doing? Why is that what you're doing? Because you might get your head bitten off. But he knew that that is where lives get saved. And then it happened. During a case, a cardiac case, they were about to turn the perfusion pump on. The nurse in the room suddenly yelled, "Stop!" And then she said, I don't know whether this means anything, but there's a bubble of air 2 inches long in the tubing going back into the patient from the pump. And everyone went, oh my God. 2 inches of air would have gone straight into that patient's brain. At a minimum, a stroke, very likely death. You can't see that in that statistic there. And it wasn't because a piece of paper was on the wall. It was because that system, that protocol behind it, said we make a plan, we converse, we work on our non-technical skills as well as our technical skills as a team of people to say we understand what we're doing, why we're doing it, what is coming up, what's to be feared, what the plan is, and that we will speak up if we have any uncertainties, any doubts. And because of that, at least that one person was saved. And we know we're measuring a few hundred more just in the last year. There are more to come. It is painfully slow, but important work. And along the way, what you're doing is making a system that works. It is our generation's responsibility to make systems that work. That will be our task for the next generation. And I thank you all for the privilege of getting to come here and work with you in teaching others how to make that happen. I just want to finish with a map of the influence that your work is having. We've taken this model. It's now being applied in a nationwide effort to bring it to ambulatory surgical centers, with all of these states having more than 200 centers that are following the South Carolina model, and then individual states in a national collaborative that we've been building that are implementing this all across the country. People are watching, and we really appreciate all the leadership you're showing, not just in your own hospitals, but as a state. So thank you.